Good afternoon, everybody, and thank you very much for having me here. As many of you might be able to tell from my accent, I grew up a little bit west of here in Hamilton, but it is looking like I might be able to go home tonight. The polls are looking a little bit better. I was telling my partner it was either going to be a very big suitcase or a very small suitcase, depending on how things looked. I don't have any disclosures. I do want to acknowledge the work of the Covenant Health Palliative Care Institute in putting what I think is a very, very important conference together, and the Palliative Care Matters Steering Committee, who were invaluably helpful in helping put together both the paper and this talk. So as you've heard, what I'm supposed to address today is what have strategic frameworks and plans accomplished for palliative care when adopted by other countries. And I want to tackle this in really three ways with you. First, I want to talk a little bit about why is a national strategy needed? Why do we really need to be thinking about this? We're going to take a little bit of an international perspective and sort of very quickly review what's happened in other countries and try to draw some lessons from that. And finally, some very quick summary and recommendations. Work for people? Please say yes. Let us begin. I do, before getting into national strategies, want to point out the incredible changes that we have seen in human life expectancy over the past 125 years. And for those of you who can't read that over on the panel, the gentleman says, I'd have been here sooner if it hadn't been for early detection. Because when you think about it, when you look at Canadian life expectancy in 2013, the median age of death is now 81 years. That is over 40 years more than it was back in 1880. But that statistic hides a number of other factors. For example, how many of you in this room expect to live to 65 or are there already? And you don't have to tell me which one if you don't want. Yeah, most of us, right? So in fact, if you get to 65, age of death is not 81. Okay? It actually goes up. Whoops, sorry about that. That should be 92. So, how did we miss that? I'm sorry, it should be 88. Sorry, how did we miss that? Let me go back. That's terrible. Wow. So, let me configure myself. So, for this half of the room, because the lay panel is over there, that's the group that is going to get up to, 88, okay? You're the 50% because that's the median, okay? If you get to age 80, you can expect to live to age 90. That's not so bad, right? And there is going to be a doubling of the Canadian population, up to 9 million people by 2036. And if we eat well, exercise, and take our statins, hopefully we're going to look like this at age 85. This is actually a photo of my grandfather. He was a very successful New York City businessman. That was the American half of the family, who at age 55 decided that, he probably had about 10, 15 more years of life to live, and he thought he had enough money, so he retired. And he moved up to Maine, and when he wasn't dead at 65, and when he wasn't dead at 70, he started buying a whole bunch of forest and putting conservation acts on it. And what do you do when you have a lot of trees and nothing else to do in the summer? You have the forest ranger go out and mark the trees that are impeding growth, and you go up and you take them down, and you make firewood, and you have, firewood for the winter and lots of beautiful trees, which I now own. However, many of us are not going to inherit those genes. I would embrace the aging process if I could lift my arms, says the man on the table. So in all seriousness, let me now turn to the other half of that marriage. And let me turn now to what we are facing, both here and in the States, in terms of an aging population. Because this is a photo of my grandmother, which was taken at the exact same time as that photo of my grandfather. And at age 83, She had already developed mixed dementia. She had diabetes. She had oxygen-dependent COPD, and I distinctly remember when this photo was taken because she insisted that her oxygen be taken off, and we were very worried she was going to turn blue before we got a nice photo, and that was the day before we could Photoshop her back. She had heart failure. She had osteoarthritis, and she was dependent in most of her activities of daily living. She needed help bathing, transferring, dressing, meal preparation. And there are going to be, as I said, 9 million people looking just like my grandmother in 2036. And when we look at the data, almost all of us will spend at least 7 years of our lives just like this. And again, if we look at the data, 90% of us will experience daily fatigue. 60% of us will experience daily pain. Almost half will experience daily shortness of breath. And a third of us will experience daily anxiety. And this will not just be in the last 6 months of our life. This will be for months to years. Yeah, there we go. And not only is this going to be a public health crisis in terms of our care for the seriously ill, this has tremendous budget justifications for society. This is the graph of the climb in percentage of GDP spent on healthcare, and also the Canadian Pension Plan and Old Age Security back from 1975, projected up to 2035. And let me tell you, folks, it's not everybody in this room who's driving this curve up. It's the folks like my grandmother who have serious medical illness for many, many years. In fact, how many of you, this has been a big deal in my adopted country down south, how many of you heard that most of healthcare spending happens in the last end of life, last 6 months, a year of life? Wrong. That's actually an artifact about how the data are collected. When we look at the top 5% of spenders, the people driving this graph, about 49% in the US have a single high-cost event in their older years, and then their healthcare costs drop back to the mean. They have coronary artery bypass surgery, for example. Only 11% are in the last 6 months of life. The remaining 40% are folks just like my grandmother, symptom needs, family caregiving needs, but are not yet at the end of life and costing us a lot of money. So I would argue, and I'm going to come back to this in a minute, that palliative care provides a model for how high-income nations, and indeed middle and low-income nations, can help improve value in healthcare. Because we now have a wealth of data that demonstrates that people receiving palliative care have better symptoms, or better symptom control, better quality of life. The data, particularly in some populations of cancer, are demonstrating that actually people live longer when they get palliative care. Family satisfaction is higher. Bereavement outcomes are better for surviving family members. Care is better matched to patient goals. And at the same time, because we're providing the right care to the right people at the right time, we're reducing costs. Not by essentially reducing overutilization, we're reducing misutilization. Some people are getting more because they need it, more treatments. Some people get less. But the overall effects on costs are going down, particularly the need for hospitalization and intensive care units. So what are the barriers to universal access to high-quality palliative care that the World Organization calls for all nations to develop? And therefore, what are the 4 issues that any type of national strategy really needs to begin to address? First, it's infrastructure. When you think about where palliative care is delivered, hospitals, home, long-term care, we actually don't have the infrastructure to support universal access. God forbid you live in a rural part of this country or the United States. Very limited access. James has talked about the workforce issue. We will never have enough specialists in any country to care for every single person in need. It's not going to happen. And so palliative care really needs to be infused, that core knowledge and skills, into the genome of healthcare training. It still is amazing to me that after 4 years at the University of Chicago, because I trained down south, 3 years at Cornell, 2 years in a geriatric fellowship, I had a 30-minute lecture on how to manage pain. And that occurred in my first-year pharmacology course, and it dealt with how opioids, drugs like morphine, are broken down in the liver and excreted in the kidney. I left medical school knowing more about fish tapeworms than I did about how to manage pain, and that is my entire generation. My sister, who trained up here, had the exact same experience. So we have a workforce issue. We have a knowledge gap. We don't have the evidence to provide high-quality care for our seriously ill patients. Think about it. Our best treatment for pain, morphine and drugs like that, has not changed since the 1600s. We have not developed a better medication than opioids in 500 years. CIHR spends 0.03% of their annual budget on palliative care research in 2016. What does 0.03% round to? Anybody? Yeah. So it's not a surprise that we don't have the knowledge, because we don't spend it on the necessary research. And finally, we really need to think about public awareness and demand and what that means. And I have spent 25 years in the States thinking about what is the right message to the public. And as Jane talked about, Dr. Seymour talked about yesterday, we spent somewhere in the order of $220 million between 1995 and 2005 to change the culture of death and dying in the United States so that we, Americans, would embrace our mortality and see death as a natural part of life, and that we would opt and ask for good end-of-life care. What happened? Nothing. You know why? People have an abiding desire not to be dead. And if we continue to market and think about public awareness as improving the end of life, the people who truly need it are not going to opt for it. That's somebody else, because I would much rather be thought of living with the disease than dying with the disease. It is a great hypothetical experiment. For all of us who are healthy, we can think about what we would want. The reality is, though, when most of us get there, not yet, folks. So why should you have to be dying to have your symptoms well controlled, your quality of life improved, your family cared for, your length of life extended, and value increased? You shouldn't have to be. And so one of the big lessons and what made the difference, or one of the major differences down south, and it's the only time I'm going to talk about the U.S. health industry, because we don't have a system, so we can't have a national strategy, was when we fundamentally changed the message about palliative care improving end-of-life care to improving quality of life. And in fact, what we've borrowed now, and you're going to hate me for this, is that we are no longer not only improving quality of life, we are curing suffering, because everybody likes to be cured. So, let's talk a little bit about palliative care in Canada, and then let's talk a little bit about what's happening through the rest in other nations. My partner looked up at me and said, Sean, she said, you can't use organic and locally sourced because those are very good things, and you're saying this is not so good. And she's right, but I still liked it anyways. So palliative care in Canada has been organic. It has not been strategic. It has sort of grown up where there are strengths, where there have been visionary leaders, where there have been supportive institutions. And it has been, for the most part, local and locally sourced. That is, intermittent infusions of public and private money that support local programs. There have been society-specific recommendations and guidelines, and good ones. And yet there has not been, that I could find until this moment, a real national consensus on what this should be that transcends the tribe. That is, those of us who think this is a good thing to happen. And like many other countries, we have tremendous disparities in access, be they geographical, be they ethnic, be they racial. We just have tremendous disparities in access. So what countries do this well? So are there models that we can look to? It's hard, because when you look to see, how do you evaluate care for people with serious illness, the evaluations are sort of based upon these sort of composite indices that they call quality of death, which if you take a hard look at, sort of, They look at measures of service provision, sort of cost, and they look at where people die, whereas institutional deaths are considered to be a bad thing, and home deaths are considered to be a good thing. And the reality is, if you're feeling safest and your family is cared for and you die in an institution, that may not be such a bad thing than dying alone and not cared for at home. But if you look at all of that, there are 4 top performers that typically emerge. They are Australia, they are Ireland, they are New Zealand, and they are the UK. So let's take a look at those, shall we? First of all, I want to talk a little bit about the national survey, the Ipsos survey, and how it relates to this. We did that. Actually, the Covenant team did all the work around this. I just got up and got to present the results, but they did a huge systematic review of the existing literature to find out what strategies were out there. And let me tell you, folks, it is really tough. This is not published in mainstream medical journals. You have to do many, many web searches, and the work that they did was phenomenal. And I did sort of the easy things, which I picked up the phone and called people in various countries and said, hey, guys, what are you doing? So I put that in as well. So what do we find? So first of all, there is tremendous national support for this. 86%, almost 90%, say that this is the government's role to develop and implement national palliative care standards. And that 85% want these standards integrated into the Canada Healthcare Act. I mean, you don't see polling numbers like this. You just don't. The fact that almost 90% of Canadians say that the federal government should have a national plan, I mean, you just don't get that type of uniformity in any national polls. And appropriately, 70% are concerned about costs. But I would suggest that, at least looking at the data that we have, and I'll come to this at the end, it will be at least cost neutral. And it may indeed be cost savings. So, what do we have when we look out there? Well, we found frameworks for 10 high-income countries that look somewhat like Canada, and we found comprehensive multi-year strategies for only 4. And perhaps not surprisingly, they are Australia, New Zealand, Ireland, and the UK. And there are a number of countries that sort of have these general strategies which say everybody in the country should have access to palliative care. And there are some infrastructure recommendations about, well, you should have this many beds and these many specialists. And, Belgium, France, Germany, Holland, Singapore, Spain have at least that type of framework in place. So let's briefly take a look at what do these look like. So Australia. Australia began back in 2000 with a national palliative care strategy. And they actually identified 7 national programs that targeted those 4 barriers that I identified before. Research capacity, developing the workforce through education, Infrastructure through a national quality improvement system, and online resources, again, addressing both the workforce and the infrastructure. A national needs assessment, so they actually knew what the baseline was and what the problem was they were going to address. And then funding for, importantly, both clinical trials to identify what could we be doing better, and health services research to guide the national strategy. 10 years later, they were reviewed and revised. 4 new goals were identified. Public awareness and understanding. They missed that back in 2000. Appropriateness and effectiveness, leadership and governance, and capacity and capability. And then, again, 5 years later, they have just funded 13 additional initiatives, again, focused specifically on those 4 goals. What happened in Ireland? Well, right about the same time the Aussies were thinking about a national strategy, so were the Irish. And they put together a national advisory committee on palliative care that called for a very detailed plan, notably, and I think unfortunately, specifically focused on palliative care infrastructure. And they had 4 recommendations. One is they needed to enhance funding, that palliative care priorities should be based on national policy, but then they turned it over to the local health boards to say, okay, you guys go implement it. Unfortunately, without a lot of specific guidance. They said that there had to be within the health boards a separate protected budget, but what they didn't recognize was that the budgets for the health boards varied tremendously and actually didn't match up to the palliative care needs. So, for example, in an area with a very big budget, they had fabulous palliative care, and so they could protect, a fair bit of their budget. Those that had a very small budget needed a lot more money to actually bring their palliative care programs up to speed. That was a problem. And importantly, it was a public-private partnership, so that it developed this partnership between the health boards and the existing hospices, which had typically been charity or volunteer organizations. Perhaps not surprisingly, an audit in 2004 said things just weren't going the way that they hoped. They were about 90 million euros short of what they should have been investing based upon the plan. They still had a deficit of about 254 specialist beds, and said, aha, we need to do something about this. And again, focused on infrastructure. There was supposed to be a big jump in funding, moving from 54 million to up to 76 million euros. What happened, guys? Bad timing, right? Yeah, the Irish economy collapsed. And so all of these initiatives essentially have stayed stagnant in Ireland until the past couple of years, when again things have been moving forward. New Zealand presents a number of really interesting lessons. Again, national strategy starts about 2000 with the New Zealand palliative care strategy. Again, 9 components that are comprehensive and address the 4 issues that I identified earlier in their talk. And I think what New Zealand has done extraordinarily well is they have had a series of regular audits to evaluate progress towards these goals. The 2010 audit, I just highlight, big changes and efforts focused on workforce development and quality requirements, but you can see the things in the red were not as well covered. 2011, again an audit, more improvement. 2013, a better audit. And in 2015, it actually took 2 years after the 2013 audit to get this together, the New Zealand Health Ministry invested over 75 million New Zealand dollars to make this happen, including 60 new positions. And the audit and review of this was due October 16th, and it still is not out yet. So sorry, guys, I was really hoping I would have sort of the follow-up for that. And then finally, the UK, you would think, the UK, 2008, this is where the modern hospice movement started, right? Although the Irish would sort of disagree with that. And I think partially because there was such strong voluntary palliative care and hospice in the UK, it was about 2008 before a real national strategy was addressed. And, Professor Seymour is here, and, this is her country, so she can address that later. But again, very, very comprehensive that looked at awareness, education, workforce, and infrastructure. Almost 290 million pounds invested from 2009 to 2011 to support implementation. And the audit is just beginning. And the data are just coming out, and the first series of studies have been shown to show a decline in hospital deaths. But, we can argue whether that's really a good marker or not. So what are our implications? So first of all, there are a number of factors that promote success. First of all, when we look at this and we look where countries have been successful in building comprehensive palliative care across their infrastructure, they have been addressing, again, this issue of public awareness, because unless you have people demanding it, it doesn't do any good. When I diagnose any of my primary care patients with cancer, the first question I get is when I'm going to see the oncologist. When we diagnose somebody with a serious illness, the first thing they should be asking us as healthcare providers is when I'm going to see your palliative care team. The workforce issue, again, as Dr. Downer pointed out, we will never have enough specialists, and our goal should not be that every single person with serious illness is followed by a palliative care team. Palliative care teams should be following the sickest of the sick, the most complex. They should be doing the teaching and mentoring, and they should be doing the research. But the rest of us should have the core knowledge and skills related to pain and symptom management, care coordination, and communication to effectively provide primary palliative care. They have focused on research and infrastructure, and most importantly, they have involved the key constituencies within each of these 4 areas, so that they have been public-private partnerships. They have involved the researchers, the policymakers, the educators, the direct care providers, and the people who need the care. It has also been critically important, and I think one of the reasons I'm so enthusiastic about this type of meeting is the input very, very early on of senior policymakers, so they believe they have skin in the game. Because it's not something you come together, say, this is what we should do, here you go, folks, fund it. There has to be ownership by the people involved. Initiatives that promote research and promote a national system of quality reporting. Again, this idea that there are standards, we need to meet them, we are auditing them, and we are continually developing the knowledge base to push us forward so we're not staying stagnant. And then, as the New Zealanders have shown, there is nothing that drives progress better than a regular audit and, importantly, defined milestones so we can see what the progress is and seeing if we're meeting it or we're falling short. And what is the most important thing, and I'm afraid to show this? It's money. That it does require substantial and sustained investment to move things forward by the government funding bodies. Because quite honestly, our private charities, our societies, our medical institutions don't have the monies to make the change that needs to happen. And because I'm in the midst of an American election, and because one of the candidates is somebody I'd like to see as president, and one I wouldn't, I will bring you back to 1968, where there was a similar election. And at that point, Hubert Humphrey was running against Richard Nixon. Remember Richard Nixon? And I love this quote by Humphrey. This was actually the last speech he made before he died. And what Humphrey says is the moral test of government is how that government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped. And despite all the arguments that I have hopefully made about why palliative care needs to be integrated into a national strategy, I think the fundamental argument is it truly is a test of how our government cares for its people and its population. And you know what? If it costs a little bit more to make sure that somebody is comfortable, their quality of life is better, and their family is taken care of, aren't those dollars well spent? So thank you very much for your time and your attention and for having me back home.
Thank you very much, Dr. Morrison. Another inspiring and very thought-provoking presentation. We'll turn first to the panel for questions.
Thank you, Fred. And first question goes to Earl Campbell.
Thank you, Dr. Morrison. On behalf of the lay panel, may I thank you for your very thoughtful paper and your presentation today, and for putting a nice bow around the presentation with that final quote that you had up there. It's very appropriate for today. And also, thank you for informing some of us in the room about how long we might live and what that may look like. I'm encouraged today. Thank you. In your paper, you state that palliative care's development has been organic rather than strategic, which is largely influenced by local resources and practices. You've kind of reviewed 4 that you felt have something to offer and be instructive. But I'm going to ask you, which country of the 4 that you have reviewed is the most exemplary, from your point of view, in the use of strategic planning for palliative care that Canada might consider as a model? And why did you choose that country in terms of the factors promoting success?
So it's a tough question, and I have a 2-part answer to that. The first is, if you look at specifically the national strategies, my suspicion is that it's probably New Zealand. However, because of the specifics of how small that country is, how geographically contained, I think that the lessons learned from that are important, but not nearly as helpful as the Australian model. And I think if I was going to look for a model of care delivery, I would look to Australia for a couple of reasons. One is that they have very carefully thought about each of the core components needed to affect social change, which is really what we're talking about, and have focused appropriate efforts and intensive efforts at each of those key areas. The other thing that I think the Australians have done extraordinarily well is bring in all of the parties together. Senior policymakers, funders, private sector philanthropy, healthcare providers, caregivers, and have really built a coalition that improving care for serious illness really matters to them, and they, as I said, they have a stake in the game. That being said, I think Canada has the opportunity here to really develop a model that could be emulated by a number of other countries. And I think right now we can learn from what people have done before. We can take the lessons from that. But I think the opportunity here is really to do something quite magical. And to think through what is the generalizable model in 2016 that will get us to the point where a country can say we can provide high-quality care for all people with serious illness. Certainly, we can't do that in the States. We just don't have we don't have a national health system. We've got an industry. And we haven't done the right steps that have started to happen here. There haven't been national conferences like this. The public opinion polling that led to this is incredibly important. The support from the people we take care of saying we should be doing this. So actually, I would look to the other countries. I would draw important lessons from all of them, but I wouldn't model yourself on any of them. I think this is the real opportunity to do something unique, innovative, that others can emulate. And please do it by the time I turn 65 when I come back here.
Thank you.
In French, once again, if you want to use your headsets.
Your translation devices, channel 1 for English, channel 2 for French. And I will grab you.
No, no worries. Down in the States too long. With apologies, my father grew up in Montreal. My French before I left this country was reasonable. It is not anymore.
All set. En lisant votre rapport,
Reading your research report for this conference, I was surprised to read that when Belgium wrote in its laws that it was a right, palliative care, because the Belgians went very far, that really stimulated my curiosity. And I did some Google research to see what was what. And I was even more surprised to find that the Prague Charter on Palliative Care and the primary organizations that are involved, a world organization that's involved in palliative care, recognizes it as a right. We can imagine that such a right in Canada would have major repercussions in a huge country like Canada, with 2 or 3 people per square mile. Did you find in your research if other countries made palliative care a right? And what were the implications? It may be easier in a country like Belgium, which is smaller. So what did you find, and were you advised that about a strategy that we could propose to the government? Thank you.
Belgium has established that palliative care is a right. And the World Health Organization, in their recent declaration, also has said that every country, palliative care should be a right for every citizen. The issue with that, and I will be very honest, is those are words. That without a strategy, without a plan, without investment to ensure that that happens, it essentially just remains words. And if you look at Belgium, for example, even though palliative care is a quote-unquote right, there are still tremendous disparities in access. Most Belgians actually do not get high-quality care before the end of life. And in some ways, I think it gives people a pass to say, we've passed a law, it's a right, we can move on. So I think my belief is that palliative care is a right, that people should have good symptom management. They should be comfortable, that it is an integral part of healthcare. But saying that is not going to move us forward. So I would suggest that rather than thinking about telling the government, you have to establish it as a right, let's think about how we actually are going to develop a healthcare system where it truly is a right, so we don't need a declaration like that. Does that make sense?
Penelope, next question, please.
Thank you for a very interesting talk. You touched on possibly reducing costs or possibly shifting costs, and obviously it's a bit problematic to use that as a selling point in this situation, but clearly it's a major issue and some sort of carrot for a government. Can you expound on that a little bit?
Yeah. So when we look at data that have looked at the effect of palliative care on healthcare costs, where the savings have come are really around identifying and talking with patients and families about their goals and effectively matching treatment to those goals over the course of a serious illness. And by enhancing quality, costs go down because you make it a much more efficient system. When we look at the people who really need palliative care, it's probably about 10% of the population at most, maybe 5 to 10%. So our healthcare system is actually built for the 90%. And that 5 to 10%, although they are the most vulnerable and have the greatest needs, they're still an outlier. And, it's like trying to land the space shuttle at, the Ottawa airport. It's a plane, looks the same, but the system's not set up designed to do that. So I think part of the argument is to focus on the quality piece, to focus on that bar, but also to measure the costs as you go along. Will it be cheaper? My suspicion is it will probably be cost neutral. Probably isn't going to be much more expensive, but I would argue that even if it is, we should think about how we value that investment. But you're right, the costs come as an added bonus. They shouldn't be what's driving it. And I would also add, and I think this is a real concern and issue, is we should be crystal clear about measuring whether we are shifting costs onto the families while we take them out of the system. Because if we truly can provide a safe, supportive environment for people at home and not in the hospital, then we need to be very clear about what the family is doing to provide that care. Because they're not paying for each of those hospital days, but they are paying for that person to stay at home. So we have to really have a very good eye both on measuring the cost to the healthcare system, the formal costs, but also auditing and tracking the cost to the families as well.
If I can just interject for a minute, do you think there would be a lot of cost shifting in the model of providing end-of-life care? Or do you think that that would be minimal and it would be a new cost that we would have to absorb?
I think it would probably be about cost neutral, if not more, if not savings. Because again, if you're focusing on people right at the end of life, that's probably about, even up here, about 10% of the high-cost users who are spending in the healthcare system. So we're not going to save a lot of money on that group, no matter which way you go. But we can certainly improve those last days, months of life by providing an added layer of support where they want to be cared for rather than, in Dr. Downer's ICU.
Well, and if the Canada Health Act were paying for it, even if people were dying at home, one would assume that there would be nurse practitioners or nurses or other people in the home, and they would be paid for by the government insurance. And so not all of the cost would be shifted onto the families. A lot of it would be just spent in the home rather than in the hospital. Would that not be true?
That's what I would hope. I think that, however, and that's what I'm hoping, and that's what I think would happen in a four-sided country like this one, where it's not all about cost containment. But I do think we have to be aware of the possibility of the increased costs on families, and we should just monitor that. I think you're right. I think people will be protected, but I think we should just look at it because we're all, those curves are not sustainable.
Well, I think if it's in the Canada Health Act, a lot of it would be covered, in the, kind of the physical part of it, the mental anguish and the things that affect a family with a death in the home, of course, are not financially compensatable anyway. So, yeah. Now, Serena, I think you had the next question, then Ken.
That was a fantastic presentation. Thank you. I love how you did highlight organic, and it certainly speaks to the strengths that we see across the country with the teams, and had a very fascinating discussion with somebody at the break. So lots of strengths, but in pockets. And it really lends the thought that we were discussing on our group here about sometimes we don't know what we don't know, and how important this whole overarching structure is going to be. I'm really curious from you, if we were to look at a magical, and I love that term, national strategy, and yet we still have to get this rolled out in PEI, in Ontario, and Northwest Territories. If someone granted you the wand, what would be the 2 recommendations you would want to ensure provincially that we put in as precautions or thoughts?
Or thoughts, yeah. So first of all, I think there is, because it developed organically, there is tremendous strength in pockets.
Yes.
And, clearly to build on those strengths.
I agree.
So the first thing I would say is don't reinvent the wheel in places that it's working. find out, what is the audit, what works, what doesn't, and what can be adaptable to other parts of the country. In other parts of the province, and I think that is the first step. The second is, I think this really does, I'm a wonky researcher at heart. And so one of the things that I think that the New Zealanders did extraordinarily well was a comprehensive needs assessment. And to spend the money to see where are the gaps, what are the gaps, and then how can we begin to fill it. And I think that's part of the importance of building from the organic development of strength into a national strategy. Because if we continue to build upon the strength, we don't see where the gaps are. We don't see where the need is. And so my recommendation is, right now, let's see where the gaps are, and let's think very clearly about how we're going to fill them, and most importantly, what are the right models? Because the model that works at University Health Network ain't going to work in PEI.
Right.
And we have to be open to new models.
Thank you.
I'll just echo everyone else's comments about a wonderful presentation. So we have a government right now that, for a variety of reasons, including presumably political palatability, is committing $3 billion to, I suppose the health minister just said, to home care, including palliative care, regardless of other issues. But that seems to be considered outside of the development of a national strategy, which of course seems ridiculous, right? Why not develop a strategy, cost it, allocate funding in relation to the objectives of the strategy, and go about implementing it, which seems to be what the other examples that you've pointed to have done. So we can critique the government in this regard, or we can perhaps look to those initiatives and ask a question, and that question might be, what were the political opportunities that allowed uptake of a national strategy in those contexts at those particular points in time? Was it a particular government? Was it tenor within the medical community? Was it political pressure from patients? Where was the real sort of source of the motivation for this, or a combination of all of those? And how might we pick up on that to encourage the government of Canada to take up the idea of a national strategy?
Yes. I mean, I think it was, I don't think there's a simple answer, but I think when you look at what were the key factors that led to this, I think there were a number. I think first was public recognition of need. In the States, this was Jack Kevorkian and the assisted suicide movement in the 1990s, and a large national study that demonstrated horrific care for people with serious illness. That was the wake-up call that led to us beginning to do something. So I think it's recognition. I think also it's relationships, exactly as you pointed out. It was somebody in government who saw this as a need, who took this on as their initiative, and collaborated with multiple stakeholders. And those stakeholders were policymakers, payers, philanthropy, and most importantly, patients and families, so that it really involved the key stakeholders moving it forward. And I think the other big key to success, which I think you highlighted fairly dramatically, was the idea about getting people in early, so it was a collaborative effort, not imposed by either the government says we're going to spend $3 million on this, or somebody needs to do something. And then I think the other key issue that helped was that when this worked, it was a model, that people felt really good about it, that they could see success, that success was shared, and it moved things forward. And I think if you contrast New Zealand versus the Irish experience, where Ireland, the audits consistently showed we're not keeping up, we're not keeping up, we're not keeping up, we're not keeping up, we'll just throw more money at it. And the New Zealanders just said, we're keeping up and we're doing really well in some things, not so much in another. How do we focus on that one? That's a very different paths to address the same problem. And I think the Australians did that particularly well, is they're continuing to audit and really focus on where are the gap areas as a collaborative approach rather than just as sort of one. And it takes people to continue to push on government. There's no question about it. Political pressure helps.
Fred, I sense you're telling me time is up, am I right?
No, I'm not done.
Oh.
We have some more time for the panel and then for the room.
Well, if I could have another question then, and it kind of follows on from what you were saying. I mean, one of the problems in Canada is that the provinces deliver the health care, the federal government partially funds it, and the provinces fund the rest. It seems to me in Ireland they have a different system, but it seems that they tried to get into our system by giving it to the local health authorities to actually create the programs in their areas, while they had a national objectives set by the national government. And you're saying that really didn't work. What happened? There was palliative care in some health districts and not in others, or some things were covered in some districts and not in others? How did that work?
Yeah, I mean, there's a number of, constraints that the Irish faced, which I think were problematic, including, the economy crashing. But I think one of the key issues was the inequitable access of monies. So, for example, health boards in Ireland had different strengths. They had different budgets. And the monies that were devoted were not in proportion to the amount of work that needed to be done. Does that make sense?
Well, do you mean across the board it wasn't enough, or it wasn't enough in some, but it was okay in others?
Exactly, the latter. The latter. If you had a well-financed health board, they typically had strong palliative care programs, so they actually didn't have to put a lot of money into developing it.
And they were financed locally rather than by the national government.
And the partnership, yep. That being said, I think every strategy is local. And what I was really worried about, and you hit me with it, was saying, what advice can you give, or how should we solve this problem up here? And I think we don't know the answers to that yet. I mean, I think that is really part of the work that happens next from this type of meeting, is really to think about what is the right solution for Canada and what are the steps that we need to take, because it is a different healthcare system than others that have done this. But I think there's some core lessons.
The way the federal government has done it in the past is they make something available, they make funding available for something, and they tax the entire country for it, and then the provinces tend to have to pick it up because their taxpayers are paying for it, and if they don't give it to them, then they don't. I mean, that was the way they brought in Medicare originally. Ontario didn't want it, and the Premier said, well, I guess people are paying for it, I better give it to them, even though I don't believe in it. And I think you could do that with almost anything, and palliative care would be part of it. I've taken all the questions. Carrie, you have a question.
Thank you. I do have an extra question, and thank you for your presentation to us this morning. You've identified 4 common barriers to the implementation of a national strategy, and over the course of the last 2 days, we've heard a lot about workplace gaps and how we might address some of those. But Canada is a very large, very rural and remote country, and so I'm wondering if you have any comments about strategies for identifying infrastructures that might assist in the development of a national strategy.
Yeah, it's a very good question, and it's also one that, believe it or not, we've wrestled with down south, because of some of the states that have very, very, very sparse populations. I think there are a couple of things that we need to think about in terms of addressing that issue. The first comes very specifically around every healthcare provider having core palliative care knowledge and skills, because of the issue about A, specialist level care, but B, it makes absolutely no sense to have a specialist team in a town of 150 people. So that we have to have that nurse practitioner who's delivering care to that town, the social worker who does a lot of other things with those core knowledge and skills. And I think we talk about technology and using technology, but we haven't done a really good job in terms of telehealth, in terms of telehealth consultations, in terms of telehealth resources. And I think that's a real opportunity, because it's not just Canada that's facing disparities based upon geography. There are a lot of other countries that are facing it and haven't really figured out how to do it. And I would argue that palliative care is no different than any other part of healthcare. We have to figure out, how do we deliver high-quality healthcare to people in rural communities? And I don't think palliative care is any different than cancer care, care for COPD, care for pediatrics. So I would encourage us not to think about this as distinctly different in terms of that solution, because I think the solutions we develop to palliative care can also go right across the healthcare system as well. And I wish I had a good answer to what that solution was.
Don, if I may, I'd like to follow up on your point, and I think you might have been picking up that I was thinking of some questions along the same line that you pursued. So this, what this really has to do with is the accountability for any strategy. So as someone that spent, 30 years in political and non-political life, being a party to the development of many strategies and actually owning some of them, one of the biggest problems we have in the country is that we fail to define where accountability ultimately resides. Real change, in my experience, it takes longer than one budget cycle, and it takes longer than one political cycle. And we have yet to, establish a mechanism for any strategy, in my view, that actually holds anyone accountable other than politicians, who of course change as well. So is there anything, because I think it would be an important question for the panel, is there anything that you can draw from looking at these other countries in terms of accountability mechanisms that we could think about here?
It's a really good question, so let me actually take a second to actually think about it before. I think some of the lessons, or not lessons, but some of the strategies around accountability were again around this ability to build consortiums and collaborations, because the accountability then did not simply rest with the government on one budget cycle. That accountability was shared across, I'm sorry, I keep realizing I'm giving half the room because of these guys over here. So the accountability rested with the professional societies. It rested locally, within local governments, as opposed to both state and federal. And I think that's one of the things the Australians did very well, is they shared accountability both between the states and the national government, so that they weren't always in sync and changing. And I think that was critically important. I think the other thing was the milestones and the audits. That there was always something to look at and to compare yourself to. And I think if you look at the development, you can see it skips budget cycles. Why did it take the Australians, 3 years after the last audit to put a heck of a lot more money in? Well, the government changed. So it skipped a budget cycle. One of the great things about being back here is one of the slides and the quotes I always use is from Wayne Gretzky, when somebody said, why are you better than anybody else? And Wayne said, because I skate to where the puck is going to be, not where it is. And I think one of the things that makes this successful is to have that long-range plan that, as you said, it's not going to be done in one budget cycle, and it's not going to be done within one party in power, and to be patient. Does that help?
Thank you.
I think we're sufficiently sophisticated over here. Thank you for your presentation.
Thank you.
Thank you, Don. We have a few minutes remaining before we break for lunch. We'll thank, actually, Dr. Morrison, if you don't mind. And in fairness to our audience, and I'm doing my best here to try to add some time where we can. So let's try to take a couple of questions just before we break for lunch. Sharon Mathias.
Hi. I'm coming from a family member perspective at this point, and building on your comment that in Canada it's been organic and early stage, that one of the things that strikes me is that will have saved us from the problems you get into from a strategic plan. That if we work some bottom-up learning about what we've actually learned, that it needs to be a whole society approach. And the problem with locating it in treatment of people with serious illness is it takes you into the healthcare system, as opposed to thinking more broadly. And so to think about what you've experienced in other frameworks, because with frameworks you frame, that framing it so narrowly, has anyone actually broadened the frame to say how, and the benefit in Canada that national does not mean federal, it means a federal, provincial, territorial, and probably municipal government approach, that then could be more broadly perspective. Did anybody go more broadly than healthcare?
No. But let me come back to that, because I think the answer to no, the answer that nobody has done that is it is just so complex and so siloed. And I think that people feel that you have to start somewhere. And I agree with you. I live in a country where, all of the social needs are quote unquote under the healthcare system. That's one of the reasons we spend so much money, but I hear you. I think that one of the things to think about, and it's what you pointed out, is that what really works is to have both a top-down and a bottom-up strategy. And that the development of palliative care here has been, up till now, mostly a bottom-up strategy, which is critical to form the foundation. I think what would be helpful moving forward is not only to continue that bottom-up strategy, but to put a top-down formalizing strategy on top that will reinforce each other. And, maybe we're cautiously optimistic that we can think about this as a much more beyond healthcare, but it's hard for me, and maybe it's just because I am in healthcare, to put my brain around that.
I understand that limits you.
It does. I'm sorry. It really does. I get that.
But that is the benefit of bringing a family perspective, because I also come from healthcare, and what I learned was the reason we couldn't care for my family member was that the house was not accessible. And so we didn't lack for actually pretty good home care. What we lacked was the ability for somebody to actually live in a house that wasn't set up for them anymore.
Agree. I mean, for my patients, it's simply getting access to food. I hear you.
We have time for one brief question and brief answer, and then we'll break for lunch. Sir.
Okay. Thanks, Sean. You did a great job. My question is, one of the things that we as the Canadian Society of Palliative Care Physicians have been recommending is the reinstatement of the Senior Secretariat here in Canada. And I guess I see that as that potential oversight body to start doing that top-down approach. But it needs to be done, poor Sharon Carstairs, when she was here, she got very, very little support from the government. She did a great job for what she had available as resources. And I'm just wondering if, from your perspective and looking at international perspectives, do you think in Canada that might be a good approach?
I do think it would be a good approach, because the reality is what we are really facing right now in every single Western country is the aging of the baby boomers and the incredible impact that is going to have on our society, both in an economic, from a healthcare perspective, from the fact that we don't have wage earners as big coming up to support them. So although palliative care really, and don't get me wrong, extends from childhood all the way through to old age, what is really causing the crisis from an economic standpoint is the seriously ill older adults. And I think that as a society, we have to figure out how we're going to provide care. And we have a lot of people who can do that. We have palliative care physicians, we have geriatricians, we have family docs. This is one where we really need to think about a population rather than a specialty. And if we do a really great job with those folks, with the lessons learned will help us develop the evidence base for pediatrics and for my 45-year-old with breast cancer. But I could not agree with you more.
Okay. Thank you very much. Just before I thank Dr. Morrison one more time, just a reminder, lunch is served now. It's in the Summit Room at the top of the building where you were for breakfast this morning. We're going to reconvene at precisely 1:30 this afternoon. We still have quite a bit of material to get through. Dr. Morrison, I want to thank you very much. I think pending the results of tonight's election, if you are in a position where you're looking for sponsors, you'll find more than a few in this room. So
I'm a dual citizen. I don't need sponsors.
Okay, well, there you go. He played it right the first time. Thank you.